All right, welcome. This is the role of street medicine and other field-based services in behavioral health service delivery. My name is Charles Robbins. I'm a principal with Health Management Associates and delighted that you all are with us today for this exciting topic. This is part of our webinar series, and I am going to turn it over to my colleague Meyer to take us through some housekeeping, some important first steps.
Great. Thank you so much, Charles. And now, without further ado, I'm super excited to present to you today our wonderful presenters, Brett Feldman and Nye Kasich. We are happy to present to you, Brett. So I'll give it to you now.
All right, thank you very much. It's wonderful to see you all. My name is Brett. I'm the director of street medicine at USC, and also the vice chair of the International Street Medicine Institute, which is a very fun position to be. I get to travel all around the world and help start new street medicine programs. This last year, I crossed my 200th program that we've helped start, and I've been practicing street medicine for 20 years. Family medicine in street medicine. And I,
Great, thank you. I see a lot of familiar faces and welcome back to those returning participants. And for those who are new to these webinars, my name is Nye Kasich. I'm principal at HMA, serving as a Central Region liaison. I bring over 25 years of executive experience advancing healthcare equity and access to care through program development and operational and technology-driven improvement strategies. I'm supporting this project and I'm drawing my health plan background to foster healthier communities and positively impact lives. So if we go to the next slide, I wanted to walk you through today's agenda. So we're going to be providing an overview of street medicine and other field-based services. We'll be discussing care model and scope of services, as well as opportunities to impact systems and community. And we'll be also talking about strategies for implementing field-based services. And of course, at the very end, we'll be going through some Q&As. We'll be highlighting some of the Q&As that you'll be including in your chat. So we do appreciate any questions and please do include it in the chat. In terms of today's learning objectives, at the end of this session, participants will have an increased ability to describe street medicine and other field-based services and their roles in caring for people experiencing homelessness with SUD, explain the makeup and roles of field medicine team, as well as identify 2 or 3 outreach strategies for effective engagement with people experiencing homelessness with SUD. So the first section will provide an overview of street medicine and other field-based services. But before jumping into this topic, we want to take a moment to review the AFBSS requirements. And this might sound very familiar to you, but wanted to make sure that we provide a little bit of background and level setting. So counties are expected to strengthen or establish efforts in 3 key areas. They're data-informed targeted outreach, mobile field-based programs, and open access clinic. Now together, these create multiple entry points to care. And if we go to the next slide, this slide actually shows or provides information on the survey's medication assisted treatment access requirements. And again, it's in a nice colorful chart for easy reading. And really the intent here is to proactively engage individuals who are seeking treatment on their own, especially those who are at the highest risk. And they include people or individuals who have experienced overdose and are unhoused or are involved in a justice system. The strong emphasis here is really placed on using data to guide outreach and partnering with organizations or agencies such as EMS, emergency department, public health department to quickly connect individuals to provide services, individuals to services following an overdose event. Programs should be located where the need is greatest, as mentioned, emergency room department, but also including out in the community like encampments, supportive housing sites, or syringe service programs and jails. And the goal here is to reduce any barriers and really meeting people where they're at. Counties can build on existing infrastructure. They could partner with current providers or create an integrated models that combine both outreach, mobile services, and also low barrier clinic access. And all activities must continue to follow in establish confidentiality protections. This is really important. And then lastly, just want to highlight that recognizing counties are at different stages of readiness. You all have your unique programs, but DHCS is, for that reason, DHCS is allowing a phased-in implementation approach. And so this period is between July this year of 2026 all the way through July 2029. And of course, each county will need to outline their strategies for meeting these requirements in your integrated plan. And I'm going to turn over to Brett, who's going to walk us through street medicine services.
Where I thought would be the perfect place to start is I've been very fortunate over the years to have many great mentors, and quite a few of them have lived outside. And so I wanted to start with a lesson that was taught to me that I wanted to share with you about David. And when I met David, I actually thought he was a pile of trash. So this is outside of City Hall East in Los Angeles. And at the time, it was full of encampments. And I was walking by and I saw this trash kind of rustle. I was like, what is going on? And I looked at it, and then David popped up. And he started coming or walking around, spinning around in circles, yelling and mumbling, yelling and mumbling. And we just kind of watched him for a while. And then I saw him walk over to the first tree here, and he starts yelling and mumbling into the tree. So I thought, well, this is my chance to talk to him. And so I walked over, and it took me about 20 minutes to get this information in between all the things that were happening. But I found out that he was very itchy, that he thought that maybe he was bleeding from his head after itching so much. He wanted me to take a picture of it on my phone and show it to him. So I took the picture, I showed it to him, and explained to him that he was so itchy because he had disseminated lice everywhere. And that typically I would give him a shampoo, but because he's living outside, I would give him ivermectin, which did exist before COVID. And that if he would wait, I went to the truck, I got the ivermectin, I give him the ivermectin, I give him some water, and he drinks it down and then goes back to doing the same thing, yelling and mumbling, yelling and mumbling. And again, this all took 20 minutes, lots of patience during the time. And so I thought, well, I guess the visit's over, and I start to walk away. And then he goes to the back towards the rock bed. Well, he goes like this to me, like, wait, goes to the rock bed, and he starts picking up rocks, looking at the rocks, inspecting the rocks, throwing the rocks. And then he finds the perfect rock, this rock, and comes back, takes out my hand, puts the rock in my hand, closes it, and then goes back to doing what he's doing, yelling and mumbling, yelling and mumbling. And now this rock is one of my most prized possessions, not because there's any inherent value in the rock, but because I think what David saw was that we were trying to tell him through street medicine that we loved him, and he wanted to do the same to us. And I see this all over the world. People, no matter what their background is, they're cutting hair, they're veterinarians, they're doing anything, are using this same vehicle of love to deliver, or using whatever vehicle that they have to deliver the same precious cargo. And all of that time, it took so long to get to understand what David was telling us. And as I got to know him more, I realized that he uh, um, had been committed 5150 about a dozen times in the past 2 years. So he was connected in a way, but not had it, but didn't have any ongoing care. And so we agreed we would start some Abilify. I went 3 days in a row, then 7 days in a row to give him a pill, and then we switched to the long-acting injectable. all on the street. It didn't require another 5150, but he needed more care. And so I asked the county home team, the DMH, Departmental Health Home Team, to come. They enrolled him in their program and then eventually got him housing, and he's been there since. And so it just highlighted this idea that in street medicine, we recognize that people who are unsheltered suffer from many different poverties. And in order to solve this crisis, we have to address all the poverties that afflict them. So, of course, there's material poverty for want of a home or want of food in LA. We know that about 30% of people eat 4 or less meals a week. There's a poverty of health, physical comorbidities, psychiatric diseases, and substance use disorders that, if not treated now while they're still on the street, will prevent them from ever walking over the threshold into housing or being able to keep that housing. But the worst poverty of all, and the one that impacted David the most, was the spiritual poverty of feeling unwanted or unloved. A poverty only deepened every time a neighbor would call another neighbor to get his campment moved around all over the town, with no place to put his physical body. Like, where does he put this if it can't be anywhere? And so, in response, street medicine goes to the people first to deliver an understanding love, and then the same care on the street that you'd expect in a brick and mortar clinic. And we really look at, because I know some people on here are direct service providers and others are in a more administrative role, but it doesn't matter where you are. We look to Gandhi as part of our compass, and on which way to go. And he says, when in doubt, call to mind the face of the poorest or weakest person you've ever seen and ask yourself if that policy will be of any use to them. And so we have a new policy, the BHSA, and we have Prop 1 coming, but we also have policies that are unique to our practices, unique to our own cultures and our own communities. And that's a great place for any of us, no matter how we're implementing these policies, to start. Think of that very last person. And the idea is too often we make policies for the most people, but every time we make it for the most people, we leave out the very last. If we make the policy for the last person, it will serve everybody else. And it's important to know that this approach of street medicine, as I mentioned earlier in my introduction, is a international movement. These are some of the places that we are. And probably the fastest growing place in street medicine is right here in California for many reasons. We did a landscape analysis just 3 years ago, and there was 26 programs, mostly concentrated in the large metropolitan areas. And now there's at least 70 programs that we know of, mostly doing primary care or behavioral health care in the community, not necessarily all with the counties, of course. But these are all people that you can partner with. And it's not just in the large areas. There are at least 35 counties represented as this has grown. And we all come together every month and many times, other than our monthly meeting with the California Street Medicine Collaborative. That's our state association, and I wanted to invite you all to join. It's free to join. There's over 300 member organizations and about 1,000 members, and it's a place of shared learning. But before we get any further, I wanted to make sure we're all on the same page on what street medicine is and what it's not. So the definition of street medicine, both the global and historic definition, belong to the Street Medicine Institute, who also owns the trademark on the name. So they define street medicine as healthcare delivered directly to the unsheltered homeless in their own environment. So it's not done in shelters, in drop-in centers, and it's not done for people who are experiencing homelessness but are sheltered. And then for the first time it was ever defined in any bureaucratic way was right here in California. And they did this through a all plan letter, an APL. And I know some of you are thinking, I don't know what an APL is. I didn't know what an APL was either until I knew I needed one. But basically, an APL is an official communication from Department of Healthcare Services, so that's state Medi-Cal, to the health plans, instructing them on new policy. And so this is how they define street medicine. Street medicine is provided to the unsheltered individual in their lived environment. So you can see the alignment with the institute. Healthcare services provided at shelters, mobile units, RVs, or other sites with a fixed specified location does not qualify as street medicine. But if your mobile unit goes to an encampment, goes to the people, that's the key, going to the people, then it does qualify as street medicine. And now, also for the first time ever, starting in October 2023, and we worked very hard with the Biden administration to get this, it was recognized federally by U.S. Centers for Medicare and Medicaid Services. And this is defined as a non-permanent location on the street or found environment, again, alignment on the terms not described by any other place of service code. So, for example, mobile unit or RV is 15, homeless shelter is 4. So there's different codes, and where care is delivered to unsheltered homeless individuals. And there was two reasons why we thought this was so important. The second most important reason is because we had never been paid for the work we were doing. Because when you bill for what you're doing and where, and there was no where of the street. So this means now you can all get reimbursed for the care. The most important reason, though, is by recognizing the street as a legitimate place to deliver care, we're also recognizing the people who live on the streets right to life, in that healthcare contributes to people's right to life. And now we have a new term because this is field-based care, and there's a new assembly bill that was passed, which we're very, very thrilled about, that defined field medicine for us. And I wanted to distinguish between field medicine and street medicine. So field medicine is for anybody experiencing homelessness, unsheltered and sheltered. Field medicine is done anywhere outside. It's for someone experiencing homelessness done anywhere outside the four walls. So it's inclusive of street medicine and also includes mobile sites, interim housing, homeless shelters. So it's much more comprehensive. So it's not that we're erasing street medicine, it's included in this, it's just a broader term. And it's all part of the same continuum. So we're not saying one side is good, the other side is bad. All of these things are needed. It's also very likely that your teams will do more than one of these types of things. So there's not a right or a wrong answer. But it is important to distinguish the difference. And so this picture helps describe why. So there's a difference, between street medicine and mobile medicine, a philosophical difference and a practical difference. Philosophically, we want to be able to suspend our reality and meet the people in their reality where they feel most comfortable, to intentionally flip the power dynamic in their favor. Whereas even if we drive in proximity to them and we park, we take them out of their environment into our environment, we flip the power dynamic back in our favor where we don't want it. Practically speaking, it looks like this. So this is Lincoln Park in LA. I know some of you know this place. The red cross is LA General Hospital. Big county hospital, great county hospital. Everything you could possibly want medically is there. If you want to park a mobile unit near, you have to park at Lincoln Park, where the mobile van is in your upper right. And I'm glad that people park there. There are people experiencing homelessness there. They can add clothing services and shower services. But the problem we're trying to solve for in street medicine is that the largest encampment in the area is where the heart is. It's about 1.5 miles from the hospital and about 2 miles from Lincoln Park. And so if you can't leave your encampment because everything you own will be stolen to go to the hospital, you also can't leave to go to the park. Because even though a mobile unit is mobile, once it parks, it becomes a fixed site with the same barriers as other fixed sites. But I don't want people to think it's only a proximity issue or a leaving encampment issue. Some of you are familiar with MacArthur Park. MacArthur Park in LA is probably the second highest density of homelessness aside from Skid Row. And this is an area that I go to where I cover. And we started noticing that it was one of the hardest places to cover because people were coming and going. We were coming and going. A lot of people didn't actually live there. And there was 22 brick and mortar clinics within 3 blocks of the park, but less than 10% were actually getting care. And so we wanted to know, well, where are you getting care? And so we went to the people and asked them, and we found it was like worst case scenario. The hospital was the most common place they got care, and the second most common place was that they just weren't getting any care. Street medicine and the clinic were equal, but they were not equitable. when you look at the amount of resources poured into the 22 brick and mortar clinics, it far exceeded what few days a week, few hours a week we were dedicating to it, but still able to reach the same number of people. So this suggests a preference. Um, and why it's so important that we're focusing on the unsheltered population with the field medicine requirement and not all of people experiencing homelessness are because of these reasons. So 50% of people who are unsheltered have trimorbidity, physical health, mental health, and substance use disorders compared to 2% of the sheltered population, not the general population, but the sheltered population. And so that's why the focus on the unsheltered. And also another good reason to partner with your friendly neighborhood street medicine primary care team. And even though they're so sick, they are still having trouble getting care. And so what we did, this is in LA where there's a lot of field medicine. We went to the people and we asked them on the street, the total denominator, how many are insured? 75% were insured. How many are seeing their PCP? Only 7%, and only 3% getting behavioral health care. So we have to think of a different way of doing this. And one of the limitations, what our kind of role in is that there's just distrust in physicians, although I don't think it's unique to the physician profession, but the healthcare setting in general, of feeling discriminated against because of past negative experiences. It's not a general, they don't like structures, they don't like to follow rules, but something that we've earned. And it's not just a feeling. There's also evidence that there are significant disparities in care in the hospital that are people are not getting the standards of care. And so in many ways, street medicine is an act of reconciliation where we're going to the people and saying, we're sorry for what you've had experienced before, and now we're here with you to do better. And so the core makeup of a street medicine team, in order to do street medicine, you have to have at least two things. One, somebody who knows the street, and two, somebody who knows medicine. So you have to have a prescriber. Without a prescriber, so a doctor, PA, nurse practitioner, you're still relying on referrals back to a brick and mortar clinic, which they're not able to get to. And then two, you need somebody that knows the street. Depending on your organization, this might be community health worker, peer support, peer navigator, but somebody who knows the street and connect with people on that level. And as you can see, there are many, many other types of folks in the field-based FSP program. They're fairly prescriptive on what types of roles need to be part of the team. I actually really like the way that they've structured the team. There is some ability to be creative, but please look at that so you know what needs to be on the team. Um, and then another reason to partner with the local street medicine teams in this is that they're already doing a very high level of care on the street. So part of the landscape analysis, we found that, and this was done before CalAIM and before the big expansion. So I think these numbers are even higher now. But 70% were doing what would be considered full scope primary care and preventative medicine, plus diagnosis and treatment of mental health conditions, plus diagnosis and treatment of substance use disorders. 60% were doing MAT at the time on the street, completely on the street. I think that number is even higher now. But we know healthcare is more than just an office visit, even if that office is under the bridge. So 80% are dispensing medications on the street, bringing meds with them and giving them to the patients. 50% were drawing labs on the street, 40% doing ultrasound on the street, and much more. But even since the landscape analysis, which I said was a few years old, some of the biggest advances have been treatment for mental health conditions on the street. On your right is Coley King. He's a family medicine doctor in Venice, and he was one of the first people to really try and get primary care folks to practice at the very highest of our scope to treat, schizophrenia, bipolar disorder. It's very common for us to use long-acting injectable antipsychotics and practice at a high level. On the left is Shai Robb, who works with the Los Angeles Department of Mental Health Home Team. And these are folks that we partner with all the time when they need extra services that we can't provide. even though we do employ a psychiatrist, but they can bring the county services. And this has just been an incredible partnership. And then the other big advance has been treatment for substance use disorders. So this is Katya, Dr. Knop, who's one of our addiction medicine specialists. And she's really been pioneering on the street the direct to inject method for opioids, treatment for stimulant use disorders, and as opposed to the old way that we would do MAT with just Suboxone, it has been a complete game changer. And now we'll move to how you're going to think about deploying your teams. And the first question that you're going to have to answer is, what are we going to do on the street? What's our scope of practice going to be? When I started this work, the predominant method of delivering services on the street was engage, refer, treat, which we affectionately call the go fetch model. And so what this entails is you send everybody except a prescriber to the street to meet the person, build a relationship, build some trust, then refer, then begin treatment. This will never work on a population level with these folks because it assumes the only barrier is one of trust and a bus pass. And it's so much more complicated than that. I'm a little bit concerned that this is coming back because CalAIM, it's interesting. The ECM workers, they sometimes they get reimbursed even more than a PA or a nurse practitioner. And so people try and save money and they'll only want to send out some of the ECM workers. But it didn't work 20 years ago. It's not going to work now. The other one is transitional care, so transitional behavioral health care or transitional primary care. This is how we started in street medicine. The goal was to provide some level of care on the street, but eventually get them to a brick and mortar clinic. But ultimately, that aspiration was too aspirational because it was the same barriers of engage, refer, treat. We would always hit a wall, and we could prop them up a ton with a ton of resources for a visit or two, but it wasn't sustainable. And so now, our approach has been full scope primary care, which includes behavioral health care because that's how common it is. And this will have to be something that you're going to decide too. Am I going to send a prescriber out to the street, or am I going to rely on them coming back? And I hope you'll learn from our experience with this. Um, and then another place to focus on are these transitions. With this population, some folks don't they get it, but they don't call it out. Is that you're following them over two continuums. There's the healthcare continuum and the housing continuum. And the idea is that the same team on the street is following them throughout the continuum to maintain that trust and that relationship. And those transitions are some of the hardest times. And so try and make sure that it's the same team seeing them on the street that will also follow them into their housing units when we get there. The next question is, what is your coverage area? We get that asked this a lot, and especially for the counties, it seems obvious. It seems obvious because you will say, we have a geographic coverage. We are in charge of the whole county. But I challenge you to think of it a little bit differently. There's two types of coverages, geographic and population coverage. And which do we find more useful? Let's try and answer it together. So in LA, it's divided into spas, service planning areas. These are the spas, there's 8 of them. So you can see some, even though Los Angeles, we think of as large metropolitan area, the county is massive. So Spa 1 and Spa 2, Spa 3, large land masses, they can appear very rural in those areas. And yet there might be one team that's trying to cover all of those areas. And then Spa 4 geographically looks the smallest, but it's the most populated for people experiencing homelessness. So these areas are not equal. When you look at this from a population level when you look at this from a geographic level, you see the spa, the number of programs in each spa, and the point in time count. And you look at this and you could say, from a geographic perspective, there's too much street medicine. There's at least 5 in every spa. Spa 4 has 19 programs. People are tripping all over each other. But then when you look at the population level, I'll call back to this slide. only 7% were actually getting care for primary care and 3% for behavioral health care. And so these are painting very different pictures. Um, if you'd like to figure out what your current engagement is for your county, this is one way of doing it. So and these are primary care numbers. You can just translate this to whatever your panel size is going to be for your teams. But a typical full-time provider will see about 350 patients a year. You can't use the regular point in time count. You have to use the annualized point in time count because because that's how many people are experiencing homelessness over the course of the year, which is an apples to apples comparison to your panel size over the course of a year. And so you just simply divide the numbers and it'll tell you how much you need. So in LA, we need 348 full-time providers. At the time, we had a total of 33, which meant our current engagement was about 9%, which is pretty close to 7% looking at it from a population level. And incidentally, the rest of medicine does work on a population level. When you do studies on physician shortage areas, it's the number of physicians per 10,000 people. So it's good for us to be aligned with that. So when you're thinking, how many field medicine programs does my county need? You can do these types of calculations to figure that out. And now you're probably thinking, wow, I just did some of these calculations in my head. There's no way we can afford that. So here's some things you can do. So the first one is find lifeguards. So figure out where the people are and where you can be more efficient. These are some lifeguards that you can some places where you could go, but we even go to like the local liquor store or the local laundromat and people where our patients frequent often. We ask them about what their daily routine is. And if we haven't seen Joe in a while, I'm like, hey, where's Joe? He usually comes into this laundromat every day. And usually they know. All right. Now we're switching over to strategy. So hopefully this seems like a good idea to you. And how do you implement a team? So because this is for county behavioral health, I just wanted to outline these are things that you know, but it's important we're all on the same page. That mild to moderate disorders are for primary care and non-county psychiatry. So community psychiatry. That's mild to moderate. It's defined by a diagnosis. I intentionally included schizophrenia and bipolar in this category because sometimes those can be mild to moderate. There are many people that I'm treating for these disorders and doing it successfully. These are paid for by the health plans. Then SMI is the county mental health responsibility. This includes a diagnosis, of course, but also includes it has to be severe and persistent. It has to have a functional impairment. And then you get the county behavioral health services, and that's paid for by the county. So SMI, this is like one of the most important things. It took us forever to get down to this. SMI is not a diagnosis, but it's a severity of illness requiring a higher level of services that only the county can provide. And so when you're thinking about where to direct your services, you want as much of your services to go to people with SMI as you can and not to mild to moderate disorders. Um, so now when you think about what would this system, what would ideal system look like? This pyramid might help us conceptualize it. How I came up with this, there was not like a study I did, so there's no real like official scientific citation, but I asked street psychiatrists, county mental health, some street medicine providers, just give me your gestalt. And there was a pretty good um, consensus on this of what percentage of people you see would fall into these categories. So it was about 10%, they said no behavioral health needs, so small people. 70% or more thought were mild to moderate disease. So that means your street medicine, primary care, or community psychiatrist will see 80% or more of people on the street. And so we want to maximize that. And then it was very, very small at the top of the pyramid, 5% or less. Some even said 1% that require to be conserved or might require a care court or something like that. But the area that we're focusing on here that I think has the biggest opportunity is this 15%. It was like 10 to 15%, where you got street medicine, Department of Mental Health, full service partnerships. And that's the biggest gap right now. People that are too sick for us to take care of with primary care street medicine and really do need county services. Now, the arrow to the right is, I think, the key to what makes this system work is that the continuity that no matter where they're going in their behavioral health care journey, they can always have continuity with street medicine primary care. So we're likely to meet them on the street, do physical health stuff and some behavioral health. And then I might say to our county colleagues, we really need your help with the behavioral health stuff. And they come in, but we stay on in primary care. Even if they get conserved, we stay on. And then hopefully they improve. And then there's a like release valve where the county can refer back down to us. And continuity was never disrupted because our primary care stayed on. Um, all right. So how do we leverage these types of partnerships for efficiency and effectiveness? Because we all know money is getting tight. And so the goal of the counties, you want to spend as much of your dollars on people with SMI. And so how you can do this is referrals from primary care field medicine to increase the yield of each evaluation. I know a lot, I'm not saying don't have general outreach for counties, but a lot of people are spending a lot of money on that. You're really only looking for a small percentage of the population, and you're doing a lot of evaluations on people that aren't going to qualify for the program. So this is one way of getting higher yield referrals. And then if you are doing these referrals and they're not qualifying, or you are doing these evaluations and they're not qualifying for your program, then refer downstream to us for primary care and community psychiatry so that because they don't qualify for county services, they might need some types of services, and you won't feel the need to keep people because you feel bad not providing any sort of care. And so it's a matter of the right place for the patient to be within the system. Then there's the leveraging non-medical partnerships, where they can help you with a lot of the care management, housing navigation things. These are like with CalAIM services, so they can help you with enhanced care management, community supports, include housing navigation. So these are services that you won't have to pay for out of your county budget. Or you could become one of these yourself, and it could be an extra funding source. All right, now outreach strategies and patient selections and how these will impact your efficiency. So one is you could get referrals, as I mentioned, from street medicine or non-medical outreach orgs. And so the advantage of this is that you're not doing all the outreach yourself. So you're allowing them to do the screening for you. So you're going to get higher yield referrals, especially from street medicine, because just the rest of mental health gets their referrals from primary care. They don't go out and screen the entire population. So it means less time and less money spent caring for people without SMI that don't qualify for your programs. The disadvantage is this is dependent on your local street medicine efforts. If your county doesn't have street medicine or doesn't have strong street medicine or strong outreach, it might not be a good choice. If DMH decides to lead their own outreach, the advantage is you have more control over outcomes. Like if the local field medicine team just isn't referring to you, it might not be a viable option. And you end up being the primary relationship holder rather than relying on a good relationship being built by a different team. It might be tough to do that. The disadvantage is that it's inefficient. I've heard from some counties that they will do 80% or more of their evaluations don't end in a SMI diagnosis. Another way of doing this is a hospital-based consult service. So this means you would go into the hospital, meet people while they're in the hospital, and then follow them out on the street. This could be a whole different webinar, but it's one way of identifying the people most in need. These are people who have already declared that they are very sick because they've been hospitalized. The disadvantage is it requires hospitalization. So it's a little bit reactive, but in a county where you just are feeling overwhelmed and you're looking for people most in need of this very limited resource, it's one way of doing that. All right. Now, you know, we got to talk about this HR1, because this is going, in order for us to get reimbursed for things, people have to be insured. And this will be a total game changer. I know this is stuff that a lot of you have been thinking about or talking about. HR1, if you're not familiar with it, it's the big, beautiful bill that you heard about. And basically, the problem with this, where it's going to challenge us, is that it has community engagement requirements. So these are work requirements. People experiencing unsheltered homelessness are very busy just trying to stay alive, and especially people with behavioral health conditions, they're simply not going to work for many reasons. The good news is that there are exemptions, where for medical frailty, they have to be in drug treatment, which is great because street medicine can do that on the street without a drug treatment center. It'd be great if there were enough beds. There's not going to be enough beds anytime soon, so we treat them now. Or behavioral health diagnosis. So this means that we're going to play, us and you will play a central role in making sure people stay insured. The challenge with this is that currently, again, call back to that slide on how many people are engaged. If over 90% are not engaged, but they have insurance right now, that means they're passively carrying that insurance. That is not going to be possible anymore. They're going to have to see a provider, who can qualify them for these exemptions. There's some talk of the state doing this on the back end, which would be wonderful. But if they don't have any diagnosis, the state can't do it on the back end. So if we're not careful, if we don't focus on this, they could drop down to the levels that we were seeing pre-ACA, pre-Obamacare. I was doing street medicine pre-ACA. It was about 5% insured. So we'd go from current, our patients are about 85, 90% insured back down to 5. That's going to be a problem. The other thing is, it requires address verification. You can see how this is a problem for people experiencing homelessness. Citizenship verification. This is a problem, of course, for people who are undocumented, but also people who are citizens, but their stuff keeps getting stolen or thrown away and they can't verify it. And it has to be done every 6 months. So it's going to require continuity. So again, I only bring this up because this could have a major impact on our work, and it's a great place for us to partner.
Thank you all so much for viewing and participating in today's webinar. If you have any questions at all or have any feedback for us at any time, please feel free to email us at info@afbsstraining.org. Thank you so much and have a wonderful day.